We'll just wait a couple of minutes just for others to join, and then we'll start our webinar tonight. Right, I'd just like to welcome everybody this evening on behalf of the BAETS to our webinar, The Use of Intraoperative PTH. We've got some excellent speakers this evening. This is the last webinar of the year, and I'd just like to thank Sid Nagala for having organised an excellent series of webinars in 2023, and we look forward to another series in 2024. And I'd also just like to mention that there will be a BAETS masterclass in thyroid and parathyroid on the 4th of March in Birmingham, and there will also be a masterclass in adrenals this year on the 5th of March, again in Birmingham. And without much ado, we'll start the webinar.
Well, good evening, and thank you very much, Alison. As she said, we've got a interesting webinar series taking place this year, and this time we're concentrating on parathyroids, specifically the role of IOPTH in parathyroid surgery. I'm joined by an excellent panel of Saba and Tom Kurosinski, who really need no introduction. And the important thing about parathyroid surgery is it's generally very successful. Success rates 90–95% on traditional surgery is very good indeed. But there are complications associated with it. Patients become hypoparathyroid. Increased use of localization has allowed us to concentrate more on dealing with the single gland that's the problem rather than treating the entire neck. But that's created its own issues. Yes, we can use localization to identify the most obvious gland, but it means that we can miss multi-gland disease. And there's nothing more embarrassing than having a patient turn up after you think you've done a successful operation. You've got the pathology that shows you've taken that parathyroid out, and yet they've still got hypercalcemia. And that's not a position any of us really want to be in. So the question is, are there other things that we can do that can identify that abnormal gland and tell us if it's multi-gland disease? Or do we need to be doing more four-gland explorations? As I said, very successful operation and in good hands, very few complications. But we need to strive to do better. And that's where intraoperative PTH monitoring can help. Now, there's nothing new about this technology. It's been around since the 1970s. We know that parathormone has a rapid rate of decay with a half-life somewhere between 3 and 5 minutes. And we know that once you remove the responsible gland for that hyperparathyroidism, the PTH will fall rapidly. And if we can assess that, we then know that we can stop further exploration and stop further surgery. So the role of IOPTH can be in the form of either confirming that the single gland you've removed is the responsible one, or if you're doing a four-gland exploration, it can tell you that the one that you think is the most abnormal is truly the most abnormal, and you don't need to deal with anything further. Now, there are other roles for IOPTH, but we're not going to be going through these today. Now, traditionally, this was the sort of kit that you needed. This was what we had in the Western Infirmary in Glasgow for many years by initially Chris Wilson and then Carol Watson. And this needed an experienced lab technician. It took time, had to spin the sample down, run the analysis, but it did work very well. But it did take at least 20 to 30 minutes to get the result back. Now, the principle behind it was you took your sample pre or perioperatively, you took the specimen out, and you then repeated the sample at somewhere like 10 minutes. Now, there are various different criteria that are used for assessing this. There's the Miami criteria, which is what we currently use, but other areas use the Rome criteria, the Viennese criterion, or the Halle criterion. They're all fairly similar, but with subtle differences that can give different sensitivities and specificities. And it's very much open to the individual to know which criterion they're using and how successful that's likely to be. The majority of them use the 10-minute cutoff from the drop from the pre or perioperative highest level. And if it doesn't reach that 50% reduction, then generally you would go and repeat it after a further 10 minutes and then decide if you needed to re-explore if you weren't getting the result that you were anticipating. Now, this does have positives. It means that you can avoid doing a bilateral exploration in a large number of cases, but it also means that cases that you thought you were going to go for a localized approach, you're going to have to be prepared to spend the extra time and re-explore the other side. And that has been borne out by research over the years. Now, there's guidance as to how to do this. This was one of the early ones from 2009, position statement from the European Society of Endocrine Surgeons. And these are very sensible. IOPTH is recommended if the patients are undergoing a target parathyroidectomy on the basis of one localization study, or if you've got two localization studies that are not concordant. Seems reasonable. They didn't recommend it when you had dual localization, however, on the basis that if you had dual localization, the chance of there being multi-gland disease is very small. And that may be the case, but I think more and more we're seeing multi-gland disease even in the presence of dual localization. Moving on, the American Association of Endocrine Surgeons came up with these recommendations in 2016. They went further. They were suggesting that when you were doing image-guided focused parathyroidectomy, you should use IOPTH to avoid operative failure rates. And that's a strong recommendation with good quality evidence, or moderate. They did, however, also suggest that you needed to understand the role of IOPTH and what the dynamics of that fall in PTH should be. So ideally, you need to be doing it on a regular basis. This isn't the sort of thing that you just do occasionally. You need to be good at it. Back to the UK, and in 2019, NICE took a different approach. Now, admittedly, NICE work more on the economics of these sort of things and the cost effectiveness of it. But they suggested that you should not use intraoperative PTH, even for those cases where you didn't have localization in first-time parathyroid surgery. And that was on the basis of the additional time, additional cost, and the fact that a four-gland exploration is still a very successful operation. And even when it came to revision surgery, they didn't find the evidence to support it. Now, you would have thought that that would have put us off using this technology in the UK. But actually, increasingly people are using IOPTH or QPTH, depending on what you want to call it, for both targeted and also conventional parathyroid surgery. Here we're seeing rates of 30% in 2020. So there is obviously a thirst for us to be using this. And of course, the reason is that there is evidence that this works. And none of us like to be in the position of telling our patients that we've not done the operation or we've not cured their condition when there's the option of not. Now, I was hoping that the 5th International Workshop in 2020 would actually come up with some further guidance on IOPTH. It did restate the indications for the surgery, but unfortunately not a thing about IOPTH. So the question is, which of these guidance should we follow? Should we follow NICE and not do IOPTH at all? or should we follow the Americans, which are basically saying you should use it for all localization cases, and if you're going to be using it, you need to use it a lot? At this point, I'll hand over to Tom. Tell us what we should be doing, please.
So let me. Can you see my presentation?
Not yet, Tom.
Oh. Because I have to share the screen. Start video and share the screen. Apologies. Share. Can you see it now?
Tom, we can see, you just need to put it in presentation mode, please.
Yes.
That's it, brilliant.
Okay, thanks, Omar. That was a wonderful introduction. I really enjoyed sort of how you see this technology, and it is true that it's an old technology, but we know from just various other technical advances that it takes sometimes 2 to 3 decades before an invention becomes a routine practice, and IOPTH is not an exemption. So here is my title: IOPTH comes out of age. So in the first 3 slides, I just want to set a little scene, and I'm sure that you know most of the facts, but hyperparathyroidism is a very common disease, and there are about 12,000 cases diagnosed in this country. We operate on about a third of them, and these figures more or less can be replicated throughout the world. We operate on these people because they have symptoms, and we also operate on these people even if they're asymptomatic in sort of standard terms, because people with primary hyperparathyroidism who actually have an operation, they have a better survival curve than the people who are observed. And this is quite an old graph I've been using for my presentations, but you can see that the number of the parathyroid surgery in the NHS is really going up very, very fast. The second slide is about this complexity of a parathyroid surgery, that we're all scared that we'll come across 2, 3, or 4 gland involvements. But the truth is that for the majority of the patients, it is the removal of the single gland which will give us a cure. And the scenarios, I mean, this is a slide from MEN1, that you have to remove then 1 gland. They're quite uncommon. They are frequent enough to worry about it, but we always have to bear in mind that it's, in a great majority of patients, single gland disease. And obviously, we do not perform that many neck exploration, although admittedly, the 4 gland explorations had an excellent success rate. And we want to repeat that success rate through the smaller incision. So this is a 3 slides I set as a background. Now, we have 2 or 3 different techniques to localize, because the localization is very important. It's an ultrasound and a SESTA-MIB and a CT scan, and obviously those 2 very often are combined. Now, I will mainly present my own data because I think that that's probably of best value for people who are listening to it. So we've done over just under 2,000 cases with IOPTH. And as you can see, that we started looking at our series retrospectively, and we published quite a few papers on this. You can see that for a single gland disease, which is retrospectively proven single by removing single gland and curing patients, the ultrasound and SESTA-MIB are almost equivalent, and they're accurate in about 80% of cases. The problem is that neither of them is very good at localizing multiple gland disease. And here, what Omar mentioned, comes the concept of the concordant imaging. We're trying to increase the chances of positive localization. The problem with that approach is that it results in a lot of scans, and sometimes unnecessary scans. So because the preoperative imaging has sort of stalled at some stage, and ultrasound were getting better and better, and CT scans were getting better, but they were not really getting better in the last few years. They are very good as they are. You know, people started looking a long time ago for various technologies to help with decision making during the operation. So the oldest of them is frozen section, which is not very helpful because it just tells you that what you removed is a parathyroid. The methylene blue, I really don't think that many people use these techniques, as most of us can find the parathyroids without this. And obviously, please don't try that. I have tried; it doesn't work. And again, if you try to count the radioactivity on the removed parathyroid, it just tells you again it's a parathyroid. It doesn't tell you what the other remaining parathyroids are doing. So there was always a need for something else. So whichever way you want to approach the minimally invasive technique, whether it's a lateral approach, you fancy doing some lap chole type of operation on you, enlist help of the robot, or you go through the mouth, you still want to know that as a gland you removed cured the problem. And the consequences of all of these weaknesses in the patient's pathway is that we have at the moment a situation like this. The patient is told your calcium is high. Then very often, whoa, your calcium was high for quite a few years. Your PTH is high. So you have primary hyperparathyroidism. So we need to assess you for surgery. And then it's 24-hour urine collection, sometimes genetic studies, DEXA, and the renal ultrasound. You need an operation. Well, if you need an operation, you need a localization scan. You need an ultrasound. You need another ultrasound because the first one was done by somebody who was not very experienced. But if that ultrasound is not conclusive, then you need a MIBI scan, then you need a CT scan, then you need other scans, and then you can have an operation. So this is the current pathway, and I'm not saying that every single patient goes through it, but many do. A lot of unnecessary steps and unnecessary scans. Now you can only imagine how long it takes for the patients to actually earn his operation. Well over a year in great majority of cases. So when I started sort of getting interested in endocrine surgery about 30 years ago, there was this concept which was prevalent in America, that some of the hormones are disappearing from the system faster than others. So I put together a table, and I sort of and I called this table which hormones are actionable. So if you, and the PTH is obviously a very good candidate with the half-life, biological life of somewhere around 4 minutes. Renin is very good, but it really can't be used. The insulin is, you can use when you do insulinomas, but this is a very rare operation. And obviously the other hormones, especially with 30 minutes half-lives, they're really not actionable. So you know the curves, and Omar described how it works. You take the blood before the operation starts with the probably anesthetic time, then you do the blood test when you find the gland, and then 5, 10, and 15 minutes. Now, the last sort of almost 2,000 cases, I always done the same way. Of course, we never stopped at 10 minutes. We always, that was part of my desire to sort of use this data for some future research. And obviously, if you measure it on different platforms, you're going to get different concentrations. But if you express these values as percentage, a drop of, then you will see that the curve will come together. The design of the assay for all the platforms always the same, is the immunochemoluminescence or any other technique. You had you have a PTH, which is 84 amino acids, a peptide, and you need 2 antibodies to measure it. One is a stationary and one is linked to the detection particle. So this is just a very superficial introduction to what's actually happened behind the scenes when we do the measurements. The same techniques are used for main platforms. So when I started, it was all about imaging. Then we started using the main lab, but that was obviously very long. It was the days you could tell your houseman to run faster. I don't think you can say things like that nowadays. But then we're interested in a system which Omar already has shown you. And we've done all our work, both in the NHS and private, with the same equipment. And we noticed over many, many years that our results were actually very, very good. The sensitivity, you know, this machinery was telling us the truth in the great majority of the cases. Our cure rate was sort of really phenomenally high. And what is really important is that we started doing more and more minimally invasive approaches, because we knew that if that was the wrong thing to do, we will be told halfway through the operation by the IOPTH system. This system had problems. It was cost, logistic. You had to book people from the lab. They were always reluctant to release them. And each round of assay took about 12 to 15 minutes. So much faster than main lab, but not fast enough. Some of you will know that I tried to build a new system. I tried to build it on a platform of the lateral flow. We got somewhere, but I got a very good idea what the new system should be. And I said, it has to be portable, accurate, fast. It has to be so simple that it can be done by the people in theater. And to meet all this criteria, it has to be done in a whole blood, because we have to eliminate the spinning of the blood and measuring PTH in plasma. And as I was working on the system, a new system arrived, and I'm not going to describe the system in great detail because that is the next talk from the company, but it was quite exciting time for me, because after all this work, suddenly we had boxes which could meet almost all of my criteria for the perfect IOPTH assay. So what were our results over the last 20 years of using IOPTH? Well, as I said, our cure rate was very high because, well, we're not bad surgeons, but obviously our results were improved by having that incredible help in theater. And as I said before, we were doing a lot of minimally invasive operations. And you can see, because this is the same graph which I showed you at the very beginning, that the ultrasound and MIBI accuracy in identifying abnormal glands is about 80%, but the IOPTH always performs better than any of these tests or in a combination. And it is very good, not only for single gland, but also for multi-gland disease. And that we found very reassuring. So we wrote a few papers about it, and one of this paper was about patients who had ultrasound which showed a single enlarged gland. So it's almost 600 patients. As I said, all of these patients had ultrasound, SESTA-MIBI, and IOPTH. And the ultrasound indicated single gland in 452 patients. Now, as I said, it's an investigation which is accurate in about 80% of cases. So indeed, it was correct in 411 patients. But what was much more interesting group is what happened when the ultrasound was incorrect. It was 41 patients. Now, because all of these patients had a MIBI, you can see that the patients with incorrect ultrasounds, actually the results were not really greatly corrected by the MIBI, because the MIBI was correct only in 12 patients, and it was still incorrect in 29 patients. While all of this, but one, we had one patient who was not cured in that group, actually IOPTH always tells you to carry on or to stop. So it completely opened in our mind possibility of doing this operation in certain situation on the strength of the ultrasound alone. And this graph really shows two scenarios. The first scenario is the real life. So it's an ultrasound, SESTA-MIBI and IOPTH, and we had a cure rate 97.6%. And this was what we call a real life. But if we calculated a hypothetical scenario, if we operated only on the strength of ultrasound and MIBI, our success rate will drop to 94%. And if we did ultrasound and IOPTH only, the success rate went up again, up to 97. And you can see from the figures at the bottom of the slide that the most cost-effective scenario was actually ultrasound and IOPTH. And the most expensive one, when you did everything unnecessarily, less expensive was ultrasound and SESTA-MIBI, but at the cost of dropping the cure rate. So we carried on with the work on the lateral flow, and that came to an end when the new machines arrived. And they happened to arrive at the beginning of the COVID, or COVID just kicked in very soon after these machines arrived. So I enlisted the help of a friend from Germany. We designed very quickly a study between two hospitals in London and one in Stuttgart. We enlisted 234 patients who had a usual spectrum of minimally invasive conversions, bilateral neck explorations. And we analyzed the data on 912 paired PTH measurements. So each patient who was undergoing surgery had a PTH measured in 3 different ways. Both centers, gold standard was future diagnostic, so that's the orange line. Then there was an NBCL and main platform. We used 2 different platforms, Roche and Abbott, but for the purpose of this talk, there was a control group on the main platform PTH. And we divided the study into 3 phases because each phase ended up in reviewing the results and adjusting the design of the test, cartridges, hardware, and so on. We presented this data at the BTAS and at the Endocrine European Surgical Society. And essentially what we looked is the accuracy, sensitivity, and the specificity of the method. So in a phase 1, the sensitivity was not very good, and at the time there were further adjustments, mainly to the calibration curve. In the second phase, the sensitivity went up, but we had few false negatives. We think that this is by heterophilic antibodies, because antibodies which are used in this test are GOATS antibodies. So we dealt with this problem by adding a little bit more of the anti-heterophilic antibodies into the cartridge. And you can see that in the final phase, we had a sensitivity of 98.6%. Now, so this is compatible with what's the future diagnostic, but obviously this assay is much faster. Now, what is very important is that we never encountered false positives. We had false negatives, which affected our sensitivity, which means that there was no 50% reduction, but the patient was actually cured. But we never had a situation when the test told us, you are cured, or you cured the patient, and then the patient was not cured. So our specificity was 100%. So I think that this technology has got a potential to have a huge impact of how we do parathyroid surgery, and it should have an impact on the pathway as well. I don't think that this part of the pathway will change because it's a sort of IOPTH independent. We probably need some artificial intelligence or some other form of alien intelligence to help with speeding the patients through the diagnostic process. But I think that there is a huge potential to minimize number of scans. Because in my prediction is that for some years to come, we are not going to have any new imaging scans, which will dramatically change our localization success. And I think that the technology which is actually going to affect it and improve it and make it more cost effective is IOPTH. So I've been doing the parathyroid surgery for well over 25 years, and as I said, great majority of them were done with the IOPTH. So we have a quite significant experience in using this technology. What, in my view, are the potentials of this technique? It's definitely improved results. Some critics say that, well, it improved results from 92 to 98, but that is a significant improvement. It shortens the operating time because it tells you that the operation was a success and you can stop and you don't have to do the full gland exploration. It will definitely increase your ability to say, oh, this ultrasound by a good radiologist identified 2 centimeter adenoma. You really don't need any other tests, but you can go ahead with a minimally invasive parathyroidectomy, because in the unlikely situation that the radiologist was wrong, then the IOPTH will tell you that during the operation and you will just explore the neck. It has a potential to reduce number of localization scans because, again, will give surgeons confidence to operate on the strength of just one scan rather than trying to achieve concordant findings. And eventually it will reduce the costs. So in my practice, IOPTH had a huge impact on patients with primary hyperparathyroidism, both first time and reduced. But it was a significant success in two groups of patients who are much smaller groups, but they do come under, we look after this, and this is children and pregnant women, because in both of these groups, either you can't or you don't want to do too many tests, and obviously all the radiation should be avoided. And the only localization which you can perform is a non-ionization investigations, which is an ultrasound. And this is because of this that for a very long time, the general recommendation is that both children and pregnant women need a foregland exploration. I haven't done a foregland exploration in children and pregnant women for 20 years. We always relied on IOPTH with a great success. And just to prove it, this is an 8-year-old boy who had an operation just 2 weeks ago. That's the end of my talk. I'm happy to take the questions later. And thank you for listening.
Tom, thank you very much. That was absolutely fantastic. I'm sure there will be questions, but I will ask people to put them into the chat box and Sheila will field them afterwards. I'd now like to invite Rob from NBCL to do a presentation on the point of care machine that you've just so eloquently shown us. Rob, thank you very much.
Yeah, thank you, Omar, for introducing me. Also thanking Tom. Looking for the, is this visible now?
Yes.
Everyone see? Yes, okay, thank you. Thank you very much as the BAETS team as well to give us the opportunity to present NBCL, to give you a little bit of background of the company, but especially on the machine, why it was developed and how it's doing in the market. The company was founded in 2012 with the objective to develop a machine only for intraoperative PTH and to make it available anywhere, anytime, and being operated by anyone in 5 minutes. And the company is located in the Netherlands. It has its own production, it has its own development, and the company was founded by Chris, his brother, and his father. And Chris is also in the call today. He's also the inventor of the machine, and he had the objective to really make this happen in 5 minutes. And that is how the machine looks like. The machine you saw on Tom's picture. It's almost what Tom was having as his ideal product. It's not completely portable, but you can put it on a trolley, and for the rest, it almost does everything what Tom had this on his requirements list. The only thing you need is a cartridge with reagents, the same as are used as in the central lab. You need a tube of whole blood, which normally is put in the machine by an operating room assistant. You close the lid, you push the button, and after 5 minutes, you have a result printed out. And this is how it looks like in the operating room. You really need only a trolley with the machine on it. And here you see the cartridges. Here you see a larger picture of the cartridge with some code information on it. And the machine will check if it's not expired, and the machine will check if the machine is calibrated. And you will need to do 2 short controls in the morning where the machine also checks if everything works well. And that enables you to have every one of your assistants to run the machine very easily. And I will make this a little bit smaller. Just to give you an idea, we have about 40 systems now in the market. We started early 2022. We had 1 system before in Glasgow at the end of 2021. And as you can see on the map, about half of the systems are in the UK. UK is doing very well. Now we are also starting the last year in Germany and Italy, and other countries are following, and we are targeting next year to go to the USA and Asia as well. And what we hear from the hospitals when they are buying the machine, especially in discussions with the administration and the business cases which are made, that the most important arguments are speed, doing faster surgeries enables more surgeries a day, and it reduces the number of failed operations and preventing re-ops. And at the end, it also supports in reducing the longer waiting list. This is the NBCL team also on the call today. Our new colleague, Matt Thomason. Matt, can you say hello to the people?
Hi guys, okay.
Yeah, Matt started a few weeks ago, and Matt is based near Manchester. Here's your first contact point if you have questions about the machine, if you like to discuss the possibility of a demo of a trial. Chris is in the UK almost every second week, I think. Hello, Chris.
Good. Hello, good afternoon.
And Chris is running the service and the support for all your systems together with Jan. You may also have met him. We have Luke, who is also the founder of the company, running the operations and the order desk. And myself, I'm involved with NBCL now since 5 years. So thank you very much for your attention, and we will answer further questions as well at the end of this session. And as said, you can contact one of us if you have more questions as well after the session.
Rob, thank you very much. So, as he said, questions at the end, please, but we'll now move on to some complex case discussions. And Saba, I think you've got one to put to the panel. And I think Sheila's going to ask any questions that may come up in relation to that from the community.
Yeah, okay, thank you. Thank you, everyone. Really nice presentations. I'm not sure about my case being complex, Omar, but I'll start. Good evening, everyone. I hope you can see my... Oh, sorry, beg your pardon. I think I've got the wrong slide on. You can see the slides, right?
Yes.
Okay. So we thought we'll discuss some cases and our use of NBCL, and then ask some questions of the panel. The panel for my cases will be Omar and Tom. I've got a picture of the parathyroid glands, the superior and inferior, that can be found in various locations, and I'm increasingly finding it useful to mention in my op note what the location is, because we can't draw on our operation note. It's all electronic. So if I find a superior gland, I make a note in the op note as to whether it was in zone A, B, C, or D, and for the inferior glands, whether it was D, E, F, or G, as shown in this picture. I hope that is self-explanatory. I put this picture up just so it'll make sense when I'm describing the cases. So, okay, the first case. So we've got a 78-year-old man, raised adjusted calcium levels, raised PTH, urinary calcium indices are all consistent with primary hyperparathyroidism. So that's the diagnosis made. In terms of, does it need an operation? He had osteoporosis on the DEXA scan, and he's got a history of recurrent kidney stones. So there's clearly an indication for surgery. So that's another tick. And then we aim to localize the parathyroid glands. An ultrasound scan and a MIBI scan were done, and that's our usual practice. We get both of them requested at the first visit, or the endocrinologist do it for us. They're both negative. So in patients with negative scans, we proceed to a neck exploration. We don't, in first-time surgery, do further scans, such as a 4D CT and choline PET. We reserve that for reoperative cases. So the plan was to proceed to a bilateral neck exploration and use IOPTH. This case was done about 6 months ago, and I've been using IOPTH, the NBCL one, since about April 22. Any questions on this so far, Omar and Tom?
No, it looks fairly straightforward, reasonable. Tom?
Yeah. Agree with the plan?
Yes, I think that it all very much depends on how much onus you put on minimally invasive surgery, because obviously you could have taken one step further and do a CT scan, because there was always a possibility that the CT scan actually might identify a target. But what your practice is entirely reasonable. I agree.
Okay, so I do a pre-incision ultrasound scan. I couldn't see any parathyroid glands, just like what the radiologist said. There's nothing to see on the ultrasound. I do an ultrasound guided block as well, so that's all part of the procedure just at the start of the operation. I explored the left side first, because on the MIBI, I thought there was some asymmetry, and often, even if the MIBI scan report is negative, if you look at the MIBI scan and find a bit of asymmetry, either at the upper pole or the lower pole, then often we find that the abnormal gland is on that side of the asymmetry, or the side of the increased uptake. So on the left side, I saw an enlarged left superior gland. This is zone BC, prolapsing behind the inferior thyroid artery. I thought I could see an inferior gland in the thymus. Looked at the nerve and the inferior thyroid artery. We preserved those, and we removed the left superior gland. And the weight was 570 milligrams, so it's a good sized gland. We did the intra-PTH. You can see the numbers on the screen. The current practice is to rely on NBCL intra-PTH. We also take samples simultaneously for the lab, but the lab results aren't available during surgery. It's kind of, we just wait for the lab results the next day. It's an ongoing validation that our lab colleagues are happy to do, so we can ensure that we're getting consistent results with the NBCL. So you can see that the basal was 15, and then 12 at 0 minutes, 8 at 5 minutes, 10 at 10 minutes. And then I think there was a little bit of oozing or bleeding, and I was wanting to explore the thymus a bit more, just to make sure there was indeed a parathyroid gland there. So we took another sample at 30 minutes, and we got 11.8. So would you agree that there is not a sufficient drop?
Yes, I don't think
Yeah. So we're not happy at this point. Like I said, the patient was dual negative on the ultrasound and MIBI. We've got a big gland. I don't think there's any doubt that this was indeed a parathyroid gland. So I'm thinking this is probably multi-gland. So we carried on with the exploration. I did dissect out the left thymus and then opened it, and the left inferior parathyroid gland looked really normal, and I put it in cold saline, pending a decision on auto-transplantation a bit later. Went into the right side, found a large superior gland in zone C, which is paraesophageal, excised it 920 milligrams, even larger than the big gland on the left side, and I couldn't really see the right inferior. So we then did another PTH, waited 10 minutes after the right superior, did a PTH, and it dropped to 3.71. Are we happy? Happy to stop at this stage?
Yeah, I think so.
Yes, yes, I think so. I mean, what is remarkable about the other side you showed, that there was not just lack of the 50% reduction, but actually the hormones went up. Now, in my practice, that is always associated with multi-gland disease, because dropping, let's say 48, but not 51% is that something one can discuss. But when the hormone starts going up, that means it's a multi-gland disease.
Lovely. And then would you auto-transplant the left inferior? Would you send it to histology? I guess that's a moot point. This is a normal sized gland. I wasn't sure about whether where the right inferior was. That's the fourth gland that we haven't seen. And I wasn't sure whether I had devascularized it during the search for it. And therefore, I auto-transplanted the left inferior for what it was worth, because I thought if I devascularize the right inferior and I'm not putting the left inferior back, then we've got a significant problem with severe hypoparathyroidism. Would that be considered, do you think that's reasonable? Any comments?
No, very much so. Where did you auto-transplant it to, Saba?
In the sternemaster on the same side, usually.
Did you mark it?
No. No, I don't mark. I mean, yeah, probably could have, but you know, the stitches and clips seem to move away, and going back, I've only gone back a couple of times and to take out implanted glands, and usually they're obvious on the scans. So first post-op day, a patient is well, PTH 3.5, adjusted calcium 2.35, so we can consider that this patient is cured. We got the lab results the next day, and like I said, this is an ongoing validation of the NBCL results. We've done over 120 cases, and we carry on doing this validation because the lab colleagues are happy to do it. So fairly similar results were observed with the lab Roche assay when compared to the NBCL whole blood assay. So we're happy with that. Histology showed that both the left superior and the right superior were enlarged, nodular, and hypercellular. So clearly this is a two abnormal gland problem. And I guess the learning point for me is that if you have scan-negative disease, you've got to think about the possibility of multi-gland disease and multi-gland disease rates being higher. We do see quite a few multi-gland patients in our practice. 20% is our rate. And failure to drop certainly warrants consideration to continue neck exploration. So that's the first case, Omar. Do you want me to stop, and have you got any comments?
I have a comment, Saba. So what I do when all the scans are negative and you are sort of really going for a bilateral exploration, I would never remove the glands on the first site. Yeah. Because you very well described the situation. You cornered yourself into the two glands removed, and the third one was looking normal, and the fourth one was not seen. So the way I teach that approach to bilateral exploration, you see all the glands before you start removing them. and then one by one. But obviously you found the way out of it, so patients was not harmed. But I can't remember ever transplanting. You know, I always feel a little bit uneasy about autografting glands, because if it is a multi-gland disease, then by the time you retire, Sarah, you know, there might be a recurrence.
Yeah, so that's a really important point. I'm glad you raised it. So before we did IOPTH, when we do a bilateral neck exploration, this is until 2-3 years ago, we are a late adopter of IOPTH. I'd do exactly as you said, don't excise anything until you've explored both sides. But I might be wrong, but my concern with IOPTH is if you see a big gland, then I don't want to manipulate and mess and push around the neck too much. And so if I've seen a big gland on one side, then we excise that particular gland with IOPTH before and after, see what happens with the drop, and then proceed only if we have to. Does that make sense? I don't know how much neck manipulation upsets the PTH levels. So that I guess that's a question for you.
So it's a very important point, because the surgeons are impatient creatures, and they always keep their fingers in, and they're trying to check either a hemostasis or have just a quick look. So what really is important, that when you remove the first gland, you really have to allow the 5 and 10 minutes to be taken before you start looking again, because it is very easy to raise the PTH by touching the normal glands. And you can actually, you don't have to see the gland and touch it. You just retracting the lower lobe of thyroid with a gland somewhere there, and that will also increase. So take it out, and you have to allow 5 and 10 minute sample to be taken. And you just have to sit on your fingers or walk away, and then come back for the checking hemostasis and further exploration. I think it's very important point, Sam.
Yeah, no, thank you. I used to notice that the ultrasound, just doing the ultrasound before incision also pushed up the PTH levels. That's why we do the basal straight after intubation without us even doing the ultrasound scan. Alison, got your hand up.
Why did you think that you would devascularize the right inferior? Because you've got a level at 3.7. So why did you think you devascularized it?
So the level of 3.7 was after the second gland was excised, so indicating cure, but we don't know how further down it will go, and I hadn't seen the right inferior. Does that make sense? So I've not seen the right inferior. I've searched for it, and in and around the thymus, in and around the lower pole, and I thought, I'm not really sure whether this is viable or not. And the left inferior really was very normal size, extremely small. So that's why, is that the question? Why you put the left inferior? Because I was worried about the right inferior, because you don't know. So obviously this is 3.71 at 50 minutes, but you do it in the evening, you'll find that it goes down to 0.7, 0.5. You do it the next day. That's when you really know whether there's any viable parathyroid tissue left.
So you don't really, the 10 minutes, you're not sure whether you can trust when it goes down to the lower levels.
The 10-minute, yeah.
So
I must admit, I take a bit of a different view in that I don't, if I'm doing a neck exploration and I see an obvious parathyroid on the first side, I will find the second parathyroid on that side, and if it looks normal, I will then take out the abnormal one before proceeding. I won't find all 4 glands and explore the other side. I don't know how you feel about that, Saba.
But that's what we've done. So I don't know if yeah. Right.
Yeah, can I just buzz? Saba, do you think you would have cured that patient without IOPTH, i.e. before anyway? So just being devil's advocate.
Yeah, I guess so. So we'll do a bilateral neck exploration. We wouldn't have stopped just because we found a big gland and I guess I would have found both glands. But I mean, that's a good question. We don't think our cure rates have massively improved with the addition of IOPTH, maybe by 1 or 2 percentage points. And I think that is where we really have to evaluate IOPTH a bit more robustly in terms of the improvements in clinical outcomes. Is it just a case of 1 or 2% increase in cure rates, or is it also a number of other outcomes such as reduced operating time, reduced costs, and so on? And that's where I truly feel an RCT is the way forward, a randomized trial comparing standard surgery versus IOPTH surgery. But that's just being a bit controversial, I guess.
But the value of IOPTH, I think, Saba, in that first case, was that you did not have to spend another 2 hours finding the fourth parathyroid.
Yes, that's
Because you knew that with the level of 3, you are okay. And if you had 2 glands enlarged, 3rd normal, and 4th missing, you would probably spend a very long time finding the 4th gland.
Yeah, I agree.
And Saba, just before we move on, there's one question just on this case. I won't ask the other questions, which says, for this case, do you think the diagnosis is adenoma or hyperplasia?
I think I would simply say the diagnosis is benign parathyroid disease. The word hyperplasia is frowned upon by the last guideline from the World Health Organization. They don't want us to use the word hyperplasia. So that's why we just say single gland disease or multi-gland disease. So I've dodged that question.
But it's a good question, and it would be very good for us as a community to help to resolve this, because I operate on many endocrine glands, and actually the concept of hyperplasia in any endocrine gland, including pancreas, and this is a very dodgy area, which is made purely by finding healthy tissue pushed by the unhealthy tissue, and that is in favor of adenoma. And if they can't find that, they call it hyperplasia. But the studies which actually looked at the poly and monoclonality showed that the histopathological diagnosis really doesn't tally with monoclonality or polyclonality when the genetic analysis was done. So I agree that whether it's a multiple adenoma or hyperplasia, whatever, is just almost of no relevance.
Okay. Do you want to do your case, Omar?
Yeah, by all means. Do you want to stop sharing? Okay, so you should be able to see it now.
We can see it, yeah.
Excellent. So my case, in some ways, maybe a little bit more straightforward. We've got the diagnosis, primary hyperparathyroidism. She's been referred from endocrinology, elevated calcium, PTH, and she's 52. Complicating factor is she's got a body mass index of 56, but she is symptomatic. She's vitamin D deplete, although that was corrected. She's got borderline type 2 diabetes, and she's got obstructive sleep apnea. So this is clearly a perfect candidate to operate on. I went through Tom's diagnostic pathway. We were aiming to get a SPECT, but she didn't fit in the scanner, so we could only do the MIBI. And they suggested that there was probably something taking place adjacent to the upper pole of the left lobe of thyroid, and you can see the image there, which I think what they worked on. Didn't see anything on the basis of the ultrasound. So, on the basis of that, being a chicken, I got a 4DCT. Although probably from hearing Tom's talk, I should have just gone for a 4-gland exploration and IOPTH. And the 4DCT, they did think that there was this lesion that I've got in the crosshairs there, just above the left pole of the thyroid. But she's also got a goiter. So the first question is, should I operate? And the second one is, should I consider IOPTH? Saba, what would you do?
Yes to both, I think. So yeah,
Tom?
Fred, you've got indications, and IOPTH if you have that available.
Yeah. So
Because you know it's going to be a difficult case, and I don't know if you have considered doing a hemithyroidectomy at the same time. It certainly help your decision not to go into the other side.
Yeah, I didn't do that. And this was before we had the IOPTH. It was in that hiatus when our first machine had broken and before we got the second one. And I thought I had dual localization. I thought the MIBI and the 4DCT combined, we should go for this. She really wanted the operation. So I went in, did a localized exploration, found what appeared to be a parathyroid gland in the position as indicated by the scan. And as you can see macroscopically, this was a light brown nodule, 0.64 grams, so it's weighs a reasonable amount, reasonable size, and it was a lymph node. You can imagine how happy I was at this particular point in time when I saw that pathology report. And not surprisingly, her calcium didn't drop. Anything to make me feel better, guys?
no, I think we all been there. But you know, the IOPTH probably would have saved the day in this scenario.
Mhm.
I just wanted to add, we wrote a paper a few years ago. We look at sort of various issues which can interfere with IOPTH. We look at the renal functions, vitamin D, and body mass index. And we found the IOPTH performs equally well in all of the situations. So even this lady didn't fit in a scanner, but the IOPTH probably would tell us, you know, what the situation was during the operation correctly.
Mm-hmm. So, well, first thing was difficult conversation with the patient, who was actually very accepting of it. She did still have hypercalcemia, not surprisingly. And the first thing I wanted to do was make sure that I'd removed what I was aiming for. So I got the 4D CTs repeated, and this time they couldn't find anything. So I'd taken out what I was aiming for, but it was never a parathyroid gland. And we still didn't localize the parathyroid. So different question. Should I reoperate now? And should I consider IOPTH? And I suspect the answer to both of those is going to be yes. Tom?
Yes, I mean, you know, once you establish the indication for surgery, then the indications stay the same. The first operation was unsuccessful. Then obviously you think of a second approach with a little bit more backup.
Mm-hmm. Saba?
Yeah, the same. Yeah, IOPTH
Okay.
for this time for sure.
Definitely. So I got a consultant colleague in because if you're going back in, it could be a difficult case. She was a large lady. I wanted a safe pair of hands to work with. I was going to use IOPTH. I still felt that the left hemithyroid that we might be dealing with intrathyroidal disease, and I take on board what Saba said over the initial surgery. Maybe I should have done a hemithyroidectomy at the same time. Planning on exploring the left-hand side first of all. If, having removed the hemithyroid, if I didn't see an obvious parathyroid, the plan was to then assess a drop and only proceed to the right if no improvement. So I got Miss Watson involved. We used the MBCL machine. PTH at the start of it was 27. I took out the left hemithyroid and had a look, and after 10 minutes, it was now sitting at 40.5. So no drop whatsoever. And this ratifies what Tom said previously, that if you explore it and you don't remove it, the PTH can go up. And that's been shown in other studies. I did proceed to the right-hand side, and on opening up the right side, there was an obvious large adenoma in the right inferior position. The scans had not picked up. We got a satisfactory drop, post-excision, and I left the right superior well alone. And this time I did get it. And my learning point for this particular case was, in more difficult operations, in complex cases, go sooner to IOPTH and don't just rely on dual localization. Because I really didn't want to have to go back in a second time with this lady, but we were forced into it. Anything you'd say, Saba?
No, you said it all. No comments or questions from me.
Tom?
I think that I made this comment before, that I have this particular thing that the case is difficult. Both sides are being considered for exploration. I probably would go to the right side before I took the left thyroid out. But it was quite a big thyroid anyway, from your CT scan. So I think that was probably a good thing to do for her. Anyway, but I would just try to visualize all the parathyroids and then make a decision which ones to remove.
I must admit, I didn't see any on the left-hand side.
Yeah.
They must have been tiny. And I had a good look around the place.
So, Emma, in your practice, do you use IOPTH only for select cases, or do you use it for all of them?
I use it just for select cases. And I should probably have used it in this case. I should have just held off operating until we had the machine. It was only going to be a few months before the machine was up and running.
Same question for Saba and Tom. Do you use it for all your cases, or do you use it for specific cases? IOPTH. You've got it.
I've been using IOPTH every single case for the last 20 years. Always.
So we were previously using IOPTHs only for selective cases up to 2021, and now we're using it on all cases.
Yeah, I think that this is a very important point which our audience might want to comment on and ask questions. My view, and obviously that is a personal view, that the value of the technique is when you use it all the time, because a very simple case with double localization might prove very, very difficult, and you don't know which of these cases are going to be difficult, and more than one gland will be involved. So the point is that you have to expect unexpected. And the second point is that if you use it all the time, you get very good at it. Interpretation, the anesthetist, blood sampling, the lab people or the people in theater. And essentially, it reminds me when I started, we didn't use nerve monitoring, and then we just used nerve monitoring for selected cases, difficult to reduce, and it was a nightmare. Nobody knew how to switch the machine on and off. And now, obviously, it's being used in all cases, and it's so much easier. And I think that IOPTH probably the same rules apply.
That's very sensible, Tom. I know Saba's got another case, but I think time's moving on. I think we should throw things open for questions from the audience. So, Sheila, are there any burning questions to be asked?
Hiya. Yes. So we have a couple of questions here. So there's a couple along the same lines and one which is different. So the first one is there any value to adding autofluorescence to intraoperative PTH? To either Saba or Tom?
Maybe Saba, because he knows more about autofluorescence.
So I guess the problem with IOPTH is that it's not going to help you find the gland. And therefore, no matter how many scans you do, you will find instances where you can't localize preoperatively. And if you're doing a neck exploration and you're preparing for a bilateral exploration, the IOPTH ain't going to help you find it. So So for that particular issue, further technology might help, and that's where I think autofluorescence comes in. The problem with autofluorescence is that it will help you find normal glands, but abnormal glands often lose their fluorescent potential and may not be autofluorescence, or it might be quite heterogeneous. The other problem with autofluorescence I find is that there's a lot of false positives with autofluorescence. And we published a paper on the added value of autofluorescence in parathyroid surgery, and we found that only about 9% of instances did the autofluorescence actually add value or help point the surgeon to, oh yeah, there should be a gland, maybe that's where you need to look. So I think the jury is out on this. We really need lots of good quality evidence, comparative studies to see if autofluorescence genuinely reduces the time spent in searching for these glands and reduces the rate of hypoparathyroidism, because you don't want to damage the normal glands while you're searching for them. If that makes sense.
Yeah, I don't have great experience, but all our registrars and fellows are completely mad about autofluorescence, so they shine at everything I do all the time. And what you've said, that is exactly what I find as well.
So the next question, Omar, I think would be for you, because this is talking about your case, and there's two questions here pertaining to your case. The first one is saying, would have been any value in this situation to do a choline PET? And the second one was, interestingly, regarding to revision surgery, there is clear guidance not to revise without positive imaging, but in this case, the right side of the neck hadn't previously been explored. So would it have been reasonable to go to the right side first before the left? So two questions for two different people.
Okay. In terms of the choline PET, I would have had to have sent that to a different centre to get choline PET because we don't offer it in Glasgow. And you do get down this diagnostic escalator where you just keep on doing more and more imaging. I generally find if one imaging modality doesn't show it clearly, you're unlikely to get it showing better by doing more and more scans. In terms of the second question, I'm trying to remember what it was. Can you remind me, Sheila?
Yeah, so the second question was along the lines of, generally the guidance is you don't go back and revise the patient unless you have positive imaging. However, in this case, you hadn't explored the right side of the neck before. So would it have been sensible to re-explore this side first?
You could argue that, but the left side was the one with the goiter, and the left side had shined up. So you could argue that there was potentially positive imaging on that in the first place. And I was thinking that it could be intrathyroidal. The guidance you're referring to is more if you've done a full gland exploration, not if you've done a localized approach.
Yeah, that's a fair point. So this one I think would be for Tom, because it's something he alluded to earlier, which was saying it would be cost effective if we could move away from MIBI and just do ultrasound and IOPTH rather than justifying the cost for a MIBI. What do you think about this?
This is my practice now. So, it is very rarely we surgeons get the patients from GPs. Most of our patients come through the hands of the endocrinologist, so they end up on our table, the notes with all sorts of tests already performed. But in my practice, and I really was very happy to change it once the IOPTH sort of reasserted itself, is that my current approach is that if there is no family history, no renal problems, and the ultrasound shows 1 centimeter on bigger single adenoma, I operate on the strength of ultrasound. And I recently found out that that is not very pioneering. There are quite a few centers in Germany, Hamburg, for example, which do exactly the same. So, as I said in my presentation, we are all very worried about the complex cases, and we right to worry because we want to cure everybody first time. But good 80–90% of our patients have a single gland disease. And with the help of IOPTH, you will know during the operation whether the gland I just had a case like this. It was a good localization. I took it out. It didn't drop, and we explored, and we removed 2 other glands, and the patient was cured. And it is whoever asked the question also spotted correctly that it's a sestamibi, which is the expensive part. The sestamibi, well, it depends on NHS hospital or private sector, whatever, but it's somewhere between 800 to about 1,200,000 pounds. And if you look at the amount of the radiation, the combined sestamibi and a CT scan gives the patient is quite significant. So yes, if the ultrasound shows definitely 1 gland and it's bigger than 1 centimeter, I think it's reasonable to do it without further imaging.
So moving on from that, Tom, there is a query about, hypothetically, if you only do an ultrasound and IOPTH, there will be a small number of mediastinal parathyroids that you do miss.
Yes, I mean, there's always a game, and we should never we should always take into consideration our personal experiences, which obviously grow as you get older. I think that I can't remember a case when I had a single gland identified in the neck and there was a mediastinal parathyroid. So if you have negative ultrasound, you're obviously going to do the other scans, and my scan of preference is a sestamibi. And I also have to say that I never had a case in my life when the mediastinal parathyroid adenoma was not seen on the sestamibi, because they're usually big and very active.
So just to clarify, Tom, in your practice, you do ultrasound, and if you see a gland, you wouldn't do any further imaging, and then you'd only move on if you have negative ultrasound.
Yes, but we have very good radiologists, and they're very often sending us parathyroid, which are 8 to 7 millimeters. Now, about those, I am a little bit worried, and I would normally, if it is less than a centimeter, I would do a sestamibi. And not every single patient going through my head, through my practice actually gets it on the ultrasound alone, because as I said, very often all the scans are already there by the time they get referred. But if you remember this little diagram I showed in my presentation, that how many parathyroid adenomas were appropriately, correctly localized on an ultrasound. And if the ultrasound was not correct, then the sestamibi very rarely corrected that.
And then finally, because I'm aware of time, there's a technical question here saying, do your anaesthetists put in an art line or use venous bloods? I can say in Leeds we use venous bloods. Does anyone use an art line?
Yeah, please don't use outlines. In my life, I work with many anesthetists, and I have to fight them. You know, it's a minimally invasive procedure. Patients, you know, there's no need for outlines. They just have to find a good vein, and you know, just try to develop a good working relationship with the anesthetist. And once it settles, and you don't have a different anesthetist for every list, it works like a dream.
No, I would agree. Sid, is there anything you would like to say?
Yeah, just I suppose one final comment really, I think, for the panel, for the future of IOPTH, do you think it will eventually become the standard of care? Any ideas on how to reverse NICE guidance as a community and society? Yeah.
I think there's been a paper, hasn't there, from Liverpool challenging NICE guidelines published in The Surgeon. I think more and more data will come out and establish that adding IOPTH does add value. You just have to wait for the data, and I guess and I agree that the future 5-10 years from now we'll probably all be using IOPTHs probably in all cases, and hopefully the cost will come down as well.
Yeah, and I think.
I mean, NICE guidance is very cost related, and so as the cost of the equipment comes down, therefore the potential cost benefit ratio changes as well. So Rob et al, do your best, and we'll see what can be changed.
Yeah, thank you, Omar. We will work on that, and if the numbers grow, the chances are getting better.
Right, and then final word to Alison, as President. Thanks.
Just thank everybody for attending, for those very interesting cases. I'd like to thank the speakers, to thank Tom and Omar and Saba and Rob for very eloquent presentations. And it's good to have discussion to show that it's very variable, and it's interesting to see how other people tackle the problem of hyperparathyroidism and how we solve it and how we operate on it. I'd like to thank everybody for attending, and best wishes, and happy Christmas and happy New Year, and see you in the new year for our new webinars, and also hopefully at the master classes. Thank you.
Well, thank you.